I'm very pleased to welcome Janet Williams for our next talk. She is from the University of Iowa, and she's a professor of nursing and chair of the Behavioral and Social Science IRB, which is of great concern to many of us in the room. She is a pediatric nurse practitioner and certified genetic counselor, and she has a large body of research on a topic of great interest, which is behavioral and family genomic health. She served on multiple study sections at the CDC and the NIH and the Nursing Research Advisory Council, and she's a fellow in the American Academy of Nursing and currently serves as their representative on the National Academy of Medicine's Roundtable on Genomics and Precision Health. So thank you very much for coming, Janet. We really appreciate your being here. Let me see if I can get you started. Yes, this one. Okay. Right. So this can be used to advance the slides and as a pointer. Okay. And we have water here.
Thank you very much. Thank you to Ruth and to Paul for the invitation, and I'm very pleased to be here at Columbia today. What I'm going to focus my remarks on are actually two things. One, around the experience of genetic testing for clinical purposes. I'm mostly going to talk about Huntington disease because that's where we have the greatest body of knowledge, and quite often it's referred to as a model for other conditions. I'll also give you some information about the preclinical stages or phases of Huntington disease based on my experience in my own research and my work with the Predict HD team, and you've heard a little bit about that from Dr. Schulson. So there are four things I plan to cover: the preclinical testing, the impact on the people being tested, and I might revert back to my genetic language and refer to them as probands or participants or people at risk. I'll then also expand those remarks to talk about family of the people being tested, and then I will focus in specifically on teens and young adults in those families, regardless of whether they are the person being tested or they're in the family where there are people with Huntington's. And finally, I'll close with some remarks about ethical principles that come from the Belmont report, but I'm going to apply them in the clinical field. So this notion of preclinical, there are a lot of names. It's gone through different terms over the years. We are all talking about the same thing. It is the time period prior to the clear manifestations of a disease. And in the case of Huntington disease, that period of time in people who carry the gene mutation for Huntington disease, who do not yet have a rating of 4 on their clinical motor exam, what Dr. Schulson referred to, or the typical manifestations of chorea. So it's been called preclinical, presymptomatic, prodromal, prediagnosis. It all refers to that period of time. Each of those terms has a little problem depending on how much you think about what those symptoms are, what those signs are that people are experiencing, but they may not yet rise to the level of being recognized clinically. So we're focusing, or at least my remarks are on the purpose of genetic testing in this period of time is to predict whether or not the person will develop Huntington disease. It is not used, as far as I know, for clinical decisions. There's a lot of research going on. You've heard about clinical trials and the importance of this kind of information being useful in order to enroll people in clinical trials. But the clinical testing is also being done just for the purpose of informing the individual, am I likely to get Huntington disease or not? So counseling is a big part of this process of testing. And then people who have the test, and it is determined that they either do or they don't have the mutation for Huntington disease, may choose to enroll in observational studies such as PHAROS or PREDICT, which have ended, or other ongoing trial or clinical observation studies that help us understand more specifically the kinds of changes that do go on in this preclinical period. So as I said, I'll talk about 4 different groups. starting out with the individual who is at risk, and being at risk means that either it's your parent or your biologic parent or grandparent who had Huntington disease, the family, the bigger impact of this information for the individual and family on society, and then focusing in a bit on this younger age group. So just a bit of history, which is familiar to many of you. In 1986, the testing was possible through linkage studies. We knew where the gene resided. We didn't know what the gene's characteristics were, but we knew where it was. And so we could do linkage studies, and using family studies could predict if a person received the mutation from affected parent. And early surveys of at-risk people at that time indicated there would be a high level of interest. This was a very important opportunity for at-risk people to find out if they themselves would develop Huntington disease. But as you know, that high level of interest doesn't necessarily translate into behavior. So intent and behavior are not the same thing. And that's true, of course, in most of life. Putting this in the context of familial cancer disorders, about 50%, and that's still not a terribly high number, of people at risk for familial cancers will present wanting to know, did I inherit the gene mutation for something like hereditary breast and ovarian cancer? But for this population, those at risk for Huntington's is much lower. Going back to the cancer example, there are clinical purposes and uses of that information, and we don't have that luxury here yet with Huntington disease. So across the literature, maybe up to 20%, and in many places it's a lot lower. We heard, I think, around 10 or 12% earlier this morning. So that was the case in 1986. In 1993, then we did identify the gene. It was cloned. And it's a trinucleotide repeat. And the results that people get could be one of four types. You have inherited a gene mutation that contains 40 or more of these trinucleotide repeats, and that means that if you live a full lifespan, you are very likely, or we would say, you will develop Huntington disease. Now, these numbers may vary a little bit according to the clinical center, but these are the general figures found in the literature. If your repeat size is between 36 and 39, we might call that a reduced penetrance finding. So you do have an increased number, but it isn't a full penetrance, and you may or may not develop Huntington disease in your lifetime, and the symptoms may or may not be as severe as the classic presentation. Or you may be found to have 28 to 35. This means you probably won't show any signs of Huntington's, but if you're a male, as you go through spermatogenesis and new sperm are being formed and meiosis occurs, that is when that number may expand, and so your children may inherit a larger number of repeats than what you hold. So they may be more at risk to develop the disease than you. So there were guidelines established early on as this testing became available in the 1990s, and people were not very happy with these. They're quite prescriptive, and they are focused on being as protective as possible to minimize the risk as much as possible of adverse events following determination if you have the gene mutation for Huntington disease. These are the changes that were issued in 2013, and it was an international body that developed these. It now is recommended that genetic counseling be offered to minors. People under the age of majority think about testing, they have questions about it, they may or may not receive information in their family or through other resources. And so the guidelines suggest that information become available to minors who want to know. They can't yet consent for their own testing, but at least they can begin to have accurate information to help them think about the pros and cons of testing. I think I have never met anyone who liked the 2-month waiting period between the day a person says, I want to know my risk to have Huntington disease, go through all of the evaluations, the psych evaluation, the counseling, and then to be told originally, well, in 2 months we'll talk to you again. It's been reduced now to 1 month, and that still is that period of time for people to think about the pros and cons, so it really makes sense for them to proceed. And so there certainly are cases of people who present, they want to have testing, they've gone through all the pre-testing exams, they're ready to go, they give their sample, and they don't come back. That is their decision. So they may or may not change their mind during that month. Support has always been necessary for individuals who want to have a preclinical test for Huntington disease, and in the past the companion had to be at the visit. So a person could not come by themselves, they had to have a support person with them. And I'll talk a little bit about what we've learned as I go through my talk about this. In the European context, it's not always possible for people to be there at the visit, so they've loosened these regulations so that if the person has a support person that's consistent and reliable, but maybe not present during those visits, that's acceptable in these new guidelines. Now, informed consent must be obtained separately in order for the results to be sent to the primary health care provider, the person who is their primary physician, nurse practitioner, whatever. There have been circumstances where the persons going through the test did not want their primary health care provider to know. They didn't want it in any medical record or electronic health record. They didn't want it disclosed inadvertently without their consent. And so this extra layer of protection has been added. The counseling now must include a discussion of the potential for discrimination not only of the individual but his or her family. So I'll talk a little bit about that later on. We've been aware of the risk for discrimination for the individual at risk for HD, but they've expanded that this is a risk that should be discussed with the individual about their family. And finally, in the past, after testing, it was always possible for the individual to have a follow-up visit at the counseling center, the genetics center, the Huntington's center. Now that's a mandatory part of the protocol that you would expect to have a post-counseling visit to assess for adverse outcomes. So why would people want to have this test? And you'll notice at the bottom of my slides I've listed my citations, and some of them are quite recent. Those tend to be systematic reviews in the last few years. And then I have some that are quite a bit older. And those come from myself and others, some from here at Columbia, where we were starting to look at what's happening as we begin to get down this path of preclinical testing. So this first slide talks about why do people want to have testing, and this is a composite in the United Kingdom of over 9,000 individuals. Again, a small percentage of people at risk for Huntington disease actually present and go through the testing. It's important to keep that in mind because what we know is based on that segment, that portion of the entire at-risk population. The most prominent reason people request testing is that they say life is better if I know than if I don't know. I've had this uncertainty. I really need to know. The next most frequent is they want to make plans. So a person may say, I think, I live in a 2-story house with stairs. Maybe I need to live in a 1-story dwelling so that I don't have to deal with stairs. I want to think about my career. I want to think about education. I want to think about insurability. I want to think about whether I'm going to live close to a medical center or I'm going to go out in the wilderness and live. So it's an opportunity for people who want that information to make some decisions about their future plans for themselves. The third most common reason is that they want the information for relatives, and this can be a very tricky proposition. Sometimes relatives don't want to know, and it's not uncommon for people to say, I had the test, and there are parts of my family who did not approve of that decision, and they don't talk to me anymore. There are also relatives who really, really want to know, and they sort of push the person towards the testing. So the idea of autonomy is important here as we're talking about why people come in to have the test done to find out their chances of developing Huntington disease. Is this truly their decision? Are they doing it on behalf of someone else? Do they think the information is really important for someone else who may not feel the same way? But anyway, that's the third reason. Fourth reason is reproductive decisions. Whether or not people actually act on that information in making reproductive choices, sometimes that's the reason they say that they want the test, whether they're going to have children or have more children. And then the fifth is a hope for future treatments. Part of the counseling is to be clear that the results of the test don't help us make clinical decisions necessarily, but sometimes people find it very useful if they know their at-risk status, they know their gene variant status, that may make them qualified for clinical trials or research that's ongoing. So what have we learned through the literature, both old and new, about the impact? The first category is distress, and overall, in the United States, Canada, Australia, the UK, and Europe, we don't see evidence of detrimental psychological effects based on whether you have a positive, meaning you do have the variant for HD, or the negative, you don't. You're in the normal range. No evidence of detrimental psychological effects. However, and that's going to be a theme through most of my slides. However, a recent study in the Netherlands that had included HD and with some other neurologic disorders noted that the people who had what they called attachment anxiety, and this refers to people who say, I'm not really sure about my family, I'm not really sure about my partner or my spouse. Yeah, I have friends, but I'm not sure if I can count on them. The people who don't know, don't feel confident, there are people that they can rely on, who'll be there to take care of them and care for them, are more likely to have longer distress. I think we heard earlier from Dr. Schulson, there's a little blip in their psychological status after you get the results. It's hard to get the information, whether it's positive or negative. It tends to kind of go back down to the plateau, wherever you were, for most people, but not for all people. And this Netherlands study suggests that those who aren't confident about support may be at a higher risk. We did a study at Iowa, U.S. testing site, where we followed people as they were getting tested. And out of our small sample, we had 10 people who got negative results. And we had done interviews before and 2 times after. And we said, well, how's this going for you? I'm sorry. And the people who got the negative results weren't so happy at first because many of them thought, I'm going to have Huntington disease. I am just like my mom. We have the same hair color. We have the same sense of humor. We look alike. That has nothing to do with it. But they had lived their lives expecting they would become ill with Huntington disease. And now they got new information. They weren't. They were going to have perhaps a long life. Plans needed to be made. They hadn't made those plans. That was a shock. Relationship within the family, I've already talked about a little bit. Sometimes you're the only person that you know who didn't inherit the mutation. And so people are saying, oh, I'm going to be the carer. I'm going to be the one that's there for the rest of my family. I thought it was going to be the other way around. This is new. What's my role in society? Often people who have the negative result will say, I need to do something. I really need to contribute. And so we'll see volunteerism, participation in the Huntington Disease Society of America, other activities where they're going to give back as much as they can to benefit everybody who's at risk. Suicide risk, we've talked about a little bit here. Again, overall, no increase for suicide based on large studies and combining results across countries. However, those who, and this came from Dr. Schulson's group, those who had higher scores in the UHDRS behavior scale, which is a whole constellation of behavioral and emotional and psychiatric manifestations, were found to have a higher risk for suicide. So again, we're talking now about a subgroup of the total group. Depression, again, 2 studies that I'm citing, one from the Pharos study, one from the PREDICT study. People who have the gene mutation were found to be more likely to have depression. In the first study from the Pharos group, about 2/3, a little under 2/3. And the second one from the PREDICT study, again, a higher proportion of people in the group that had the gene mutation. We also noted that the time period between time 0 and the time that you have the manifestations of HD have been kind of quantified into thirds. So at least in the PREDICT study, the time starts in the enrollment of the study. And they've done a calculation to combine the CAG repeat size and the person's chronologic age at the time they entered the study to come up with something called a CAP score. And they've labeled them low, medium, and high. And it's a proxy for how much longer will it be until the person will develop Huntington disease. It's not a very precise predictor, but it's a little bit of a rough measure. And it was found that in this group, out of the PREDICT group, that clinically significant scores on the BDI, or the Depression Screening Inventory, were found across all the CAP groups. It wasn't just the people that were nearest, or the people in the middle, or the people who were farthest. And they also noted that the clinical presentation of depression was like depression. It wasn't different. These are individuals who have the same types of manifestations of depression, meaning that this needs to be paid attention to and needs to be managed and treated. It shouldn't be seen as something that's different from what we ordinarily would do for people. We've had some smaller studies come out of our PREDICT work, and these were looking at some other aspects of distress. One had to do with stress. How much stress did people perceive? And in this one, it was in the people with the gene variant. The highest scores were in the middle group. So I've described this CAP rating in the middle group was about 9 to 15 years from diagnosis. And it was thought that perhaps in this group there may be some subtle changes in a person's life that are hard to understand. Some changes in memory, changes in fine motor skills, changes in mood or affect. Not really clear what that's from, but people were becoming distressed about it. They were aware of it. It didn't feel good to them. As people moved towards the nearer to the diagnosis, we didn't see the high stress scores anymore, which may mean that there was less self-awareness or just less response to that. We also did a similar thing with a smaller group of couples, and so now I'm starting to introduce the family into this picture, where we used the brief COPE inventory. Now, this is a measure, paper and pencil measure that's used in a lot of clinical situations. What we found is that people were endorsing what you would expect they would endorse, except there was also an interview conducted along with administering the inventory. And it was only through the interview that we learned that there are efforts to medicate to relieve symptoms. I happen to show you the things that were prescription drugs and the symptoms that people were trying to resolve. It's quite possible people were using non-pharmacologic measures to also try to relieve these symptoms. So the point here is that, yes, there is some effort to cope with the experience of going through this preclinical time before the onset of Huntington disease, and standardized measures may not be sufficient, especially if they're not designed for this population. It also pointed out to us that couples early on will normalize some of the changes. Everybody forgets, everybody gets irritable. That normalization tended to continue for the person at risk for HD, but it wasn't satisfactory as time went by for the companion. So we started to see a divergence in scores. Everything was fine in general from the people who were themselves at risk, but not so much for the companions and those that were closer to the onset. So now I'll turn specifically to the companions and go back to the topic of preclinical testing. When we started testing at Iowa, I said, well, what's going on with the companions? We require them to be there. I'm going to talk to the counselors, and we'll see, could we do a study and ask them, how did this go for you? Are there things we could do better? And they said, well, we don't know who they are. I said, but you made them come. And they said, but we don't register them. I said, okay, well, that tells me something already about this process. So through recruitment, through the people who had been tested, they then, Snowball, told their companions, and we were able to enroll 18 companions. We administered the impact of event scale, which is a standardized measure looking at distress after a traumatic event used in a lot of different circumstances. STAI, which is an anxiety inventory, and we did interviews. On the standardized measures, there were no differences between those whose partner or friend, in some cases, had the gene mutation and those who didn't. But there were things that were going on for the companions that were helpful to us. First was that some of these companions were biologic relatives. They were offspring of people being tested. They said, I never expected that I would learn something about myself because you tested my mother or my father. So they were internalizing a lot of the information because they were now becoming aware of their risk or not risk to have Huntington disease. In the companions who were spouses or romantic partners, they were finding out either I'm going to be a caregiver for a long time or I'm not. And depending on the relationship, that could be disappointing either way. There were people who didn't ever expect they'd be caregivers. They thought they might do many things together, and they realized, well, that future now is changed. And there are some people who thought being a caregiver was a really cool idea, and then weren't going to get to do it. So they were disappointed. Most of the companions were not aware of the natural history of Huntington's disease, and this would be pretty typical experience for those of you who work with this population. They hadn't met the ancestors who had Huntington's disease, or the family stories about the individuals never used the word Huntington's disease. It was labeled something else. Or in the case of the woman who brought her coworker from work, her coworker didn't know anything except what she looked up in the library. And everyone found the 2-week or 2-month period distressing between testing and disclosure. Finally, these companions, and this may not be true of other settings, had quite variable input into the testing decision. Some didn't know anything about it. They were just told, I have to have someone. Do you have a car? Okay, come with me. I'm going to have this test. That was it. That was the sole recruitment. And the friend from work said, okay, yeah, I have a car. I'll drive you. Okay. She didn't know anything about Huntington's, was not at all involved in the decision. Some spouses were not as involved as they wished they could have been, and no one prepared them for support. The support role was hard work. It was hard work in that 2-month period because it was very distressing to wait and to one day say, yes, I am, and if they no, I'm not. I tripped on the stairs going to the basement. That must mean something. Oh, maybe it doesn't. And the companion was really at a loss of what to say or do. So that gave us some insight of what we could do better in this testing circumstance. We also then did a little more investigation with companions, and this is, of course, following the testing. And as you heard earlier, in the PREDICT study, everyone who was in the study knew their gene mutation status. That was a prerequisite for being in the study. We went to 6 sites in the United States and Canada. We met 19 people who were the companions of individuals in this preclinical phase of HD. And this was done quite a while ago. This was done before we had very much to tell people about the preclinical stages. They were observing changes, and that led to the title of our paper in the American Journal of Medical Genetics, which was Nobody Else Sees the Difference. They were saying when we see things that are different, and especially with the relationships and the irritability and maybe the withdrawing of interest in things that are going on, the companions thought it was their fault. They thought that marital problems were their fault, that anger at the children was their fault. They didn't know what to expect, and they couldn't explain these changes now, and it was frustrating when their loved one had a clinical evaluation, maybe by a local care provider, everything looked fine. So there was no explanation for them. I'm going to turn now a little bit to the impact on society. So just to summarize, there is an impact on the companion, and there are a lot of factors that go into it, but it's important to pay attention to that companion piece. So we've known, as people at risk for, or people with Huntington's disease tell us, that they experience discrimination in society. But we didn't really know how much or what kind, and so this work was done through PREDICT and Pharos, and also at the Huntington Disease Society of America. And we did a survey across the United States, Canada, and Australia to ask what kind you experience, and then to count how often did it happen. The most common was in relationships, and quite often it was family relationships. People were unhappy with the decision that had been made. Next was insurance, and across the countries, people would talk about mortgage insurance, automobile insurance, as well as life insurance, long-term care insurance, nursing home insurance, all of that. 6% said, I either didn't get a job I was qualified for, or after I told my employer and my coworkers, my job was phased out and they didn't offer me anything else. So they became unemployed. And they felt it was because they had disclosed their HD variant status. And then other transactions, across these countries, negotiating a bank loan was one example of that. I want to talk about the at-risk young adults for a few minutes. We, in this study, which was funded by the National Institute of Nursing Research, and we were able to recruit through my association with the PREDICT HD study, we did our own data collection, and this is a more recent report from Scotland. These are young women who have had testing, and in the UK, I think they're a little more liberal in deciding whether or not they'll test minors. At least that's been my experience. So it was mixed. 3 out of the 12 said it was great. Things improved. I know who I am. My relationships are good. 4 out of 12 said, well, maybe it's pretty emotional. I hated the process. I hated waiting. And 5 out of the 12 said it didn't go so well. My family doesn't approve. I'm estranged from my family, having trouble with who I am. And across all of this, again, that word loneliness and isolation comes in. They were somewhat separated from strong, reliable support. Can't count on the family. They didn't yet have secure romantic and friendship relationships as young adults. And so I think of them, back to that Netherlands study, as perhaps being in that higher risk group for adverse outcomes. We then did, in the United States, another group looked at young adults up to age 35, so there's a pretty wide range of people who had had testing. No surprise, they wanted to accomplish the goals they needed to accomplish, do it sooner, not later, hated the process. They were lonely, didn't have support from peers, and recognized the risk of discrimination if they said something to anybody. And then this was our own work, and we talked to teenagers. This was the NINR funded part. Across the United States and Canada, we talked to 32 teens whose parents said, yes, it's okay for you people to come from Iowa and talk to us in Seattle or in Toronto, two of the places of the 6 that we went. Oh, I'm sorry, do that again. We said to the teens, well, how's it going for you? What's it like living in a family where your mom or dad, your grandma or grandpa has Huntington's, and we're healthcare providers? What could we do for you? What would be better? They were watching the progress of HD, knowing that they were at risk. They felt alone in their family, and some were kind of the glue holding the family together. One girl would wash the dishes after her mom washed them because mom wasn't doing a thorough job, and it would upset mom if she said anything, so she'd just wait it out, go back at night, finish the job. That was pretty typical of these teens. We didn't ask, didn't think about it. 75% of these kids were doing the same things that I might do for my elderly parents, only they were 14 to 18-year-olds, and before they went to school, junior high or high school, they fed their parent, some of them bathed their parents, dressed their parents, got them to a daycare, got them into a safe situation so they could go to school, came home from school, repeated the cycle. They had to stay home because mom went to work second shift and they had to stay with dad. And so they were not in athletics. They weren't in swing choir, going out on the bus with their classmates. Sometimes people around them did not know. They couldn't tell their friends. It's not something you talk to with your friends. This was before social media was terribly common, so these were very isolated teens. And in our focus groups, for many, this is the first time they met another teen in a similar situation. We concluded, as far as the caregiving, they had a lot of responsibility, but they had no authority. And sometimes that caused problems in the family because they were quite logical and they were doing a really good job, although it was sometimes not something that everyone agreed with. They all brought up testing spontaneously, and they talked with each other. They didn't ask us, older people. They said to each other, what are you going to do? When are you going to do it? How do you know? And we concluded that their job in trying to be teenagers and become independent and develop their own identity and their own network of friends and relationships was harder because of these responsibilities they had. So I'm going to start summarizing here, and I have about 3 slides for that. What have we learned across the literature and in our own experiences about preclinical testing that predicts disease? Well, there are some negatives. Some people go through it and they're sorry. Their life is not better than now that they know. Some are unhappy with the life changes that this brought, and I've given you examples of people losing their jobs. Some of the people who regret it say, well, when I didn't have the testing, at least I had hope that maybe I wouldn't have gotten that gene mutation, but now I can't unknow what I know. And of course, those who did not receive the gene mutation, some went through a period of survivor guilt. There are positives about having the gene mutation test. I know I have the mutation. I know a bit about my future. I'm going to make the most of the life I have and do everything I want to do. I'm going to appreciate what I have. I'm no longer uncertain. I can make some decisions. I have some control. I have a supportive community around me now. I'm very interested in the Huntington Disease Society's groups. I want to participate in activities. I want to participate in research. What do we know as scientists? Well, our database is somewhat limited. I told you that we've learned all this from only the people who present and who are found to be able to have the testing. So that's what these findings are based on. It's difficult to do long-range studies. Dr. Schulson has talked about that after 10 years, it's very difficult to follow people. The ones I've cited are small. Many of them are small, descriptive, qualitative studies, certainly not powered for generalization. Some of the measures we use aren't ideal. We're not observing people in their coping or their stress. They're telling us. So it's self-report. Can't completely remove social desirability of what they think we want to hear. And proxies can sometimes be very good informants, proxies being companions or informed family members. We have limited data from proxies. Some of our measures don't have known sensitivity with the HD population, and I gave you an example of one of those. I've already talked about the bias sample, and we have no idea what the demand and the delivery of testing will be when testing has clinical utility. So finally, to sum up, I'll use the principles, ethical principles from the Belmont report. It's very important when you think about respect for persons to think about who wants the testing done. This is truly a considered decision on the part of the person at risk. What's the role of the family? What's the expectation of the person at risk about the family? Either the benefit that they might derive, and do they want that benefit, or do they not? Justice. Right now, our testing ideally is provided through Huntington disease centers, medical genetics centers. Not everybody has this. I gave a talk at HDSA, and I said to a woman in the audience, well, you just go to your Huntington's Disease Center of Excellence. And she said, I live in Wyoming. I don't have one. So not everybody is privileged to live near a place where they have access to and potentially reap the benefits of this kind of very carefully controlled testing environment. And then finally, beneficence. Do the benefits outweigh the risk for the individual? Are they fully informed about the risk for discrimination and what that might mean? And do they truly understand that the benefits at this time are personal, not clinical? So thank you very much for your attention. I'm looking forward to your questions and comments from the panel and as we go through the rest of the morning.
Thank you very much. With respect for persons and voluntariness, I'm curious if a person wants to know, a person in an at-risk family wants to know his or her status and doesn't want to go through this kind of protocol, is there another avenue for a person simply to get the information? Not everybody wants companions and genetic counselors and psychosocial support and so on.
Right. Not everybody does. So I can tell you a sad story where it's gone wrong. Testing is probably available from a practitioner who's willing to do it, but we hope that practitioners recognize the boundaries, and this is a different kind of test. This is not a hemoglobin. This isn't a blood glucose test. It has a lot of implications. So the story of things gone wrong is a young woman who had a kind of a minor auto accident, bit of a head bump injury. Things got a little ataxic, and things weren't quite normal. Her primary care provider did a whole bunch of tests and put in Huntington's, and it came back positive. Didn't tell her about it. Didn't tell her it was in the test panel, but did tell her, oh, I found something. You better go see the experts now. I wouldn't say that's the right way to go about doing it. I know it wasn't, but I'm talking, it's kind of a slippery slope. If there are providers who are willing to do it without these safeguards, I think there are risks that need to be very carefully considered, and I don't know if others have comments that you want to add to this or not. Dr. Schulson.
Oh, I just wanted to add there's a article by Emily Foster, OSDDR, that we published in the Journal of Huntington's Disease for people who don't want to undergo pre-symptomatic DNA testing, but want to get more information on the likelihood of sharing the gene and the onset of the gene based on the motor score that they have, and to a lesser extent on the cognitive score. They could sit down with a clinician and interpret this. There's kind of a nomogram, an actuarial table to be able to predict this, so I don't know if that address it, but that's for people who don't want to undergo testing but want more information, as I understood the question.
The question again is someone who wants to do genetics and simply wants genetics.
I think the answer is probably it's not recommended. All of these protocols were developed because of the fear that the receipt of the results would lead to increased suicide and adverse events. And the healthcare world did not feel that would be appropriate without building in what they saw as safeguards. Now, that may change. Certainly may change, especially if we find clinical utility for this test as well. So I'm going to go over here. Mm-hmm.
So, as a genetic counselor at RHC, that if you get people who don't want to go through the whole protocol, and basically what I said is, you decide to test you, but it is not required that you can find a physician who's going to do it. And then I will go through what Janet said, why it's not recommended, and that most physicians don't know what they're getting into when they're very effective.
And I think part of the loosening up of the protocol, not 2 months, 1 month, was in response to people who are not happy with the protocol.
Yeah, but speaking about exactly this stuff, it's not the first time that this issue comes around in this type of audience. And I think we should not avoid this discussion because nowadays it's very easy to have access to technologies, and it is a topic that has to do with access to technology and with autonomy and the balance between autonomy and fear. It's an ethical discussion, and we should not avoid it. The issue is, are people, informed people, and the people the right to exert their autonomy and decide they want to be tested without following the protocol. And personally, I'm a physician, and I would say if a person that comes to me, I'm not practicing in the US, but I am in Europe, and if somebody would come to me and say, I'm fully informed, I know exactly what it entails, and I still want it, who I am to be paternalistic to say no. I think we need to accept people that are aware of the information. So we cannot be paternalistic. And I think this is a discussion that we need to do.
Okay, we have time for one more question. I'm sorry to have to cut it short.
Thanks very much for your presentation, Janet. I'm coming from an HD family myself. I found everything you've said very interesting and very relevant. One question I did have is regarding the anonymity of the testing in terms of, does the protocol currently allow for people to test anonymously so that there aren't these issues of insurance, or with technology being what it is these days, it's worrisome that this, even if you're putting your social security number and somebody says, hey, we're not going to disclose this, you don't know. So personally, when I was tested, and I was able to be tested anonymously, no social security number, nothing.
I would need to go back to the new guidelines. I don't recall that they addressed that at all, but it may be in the new guidelines.
Because a member of my family had wanted to be tested, and I said, you really need to make sure that you do this anonymously. And she went to one of the testing centers, and they said, no, I'm sorry.
And it also may vary a bit by testing center, too.
Okay, I said one more, but Nancy.
All horror stories is that people misusing the test that was not done by their GP. They call up and say, well, we told you had 2 L's. What does that mean? One big, one below. A week ago, 2 weeks ago, someone called me up from the family. He hadn't been asked for the Huntington's test. The GP, knowing the Huntington's was in the family, ordered the test, called them up on the phone, and said, what was the result? He hadn't even checked it. So I think the simplistic bending over to be cautious and making sure that you understand the impact of this information. You know, bravo to you. Some of the horror stories I hear are people misunderstanding the actual data and all of the huge intensification, loss of jobs, loss of research, negative consequences. Bravo to you.
Thank you. Thank you, Jen.
So I think we're about 15 minutes behind schedule, so everything's going just fine. So our next talk is by Claudia Boga, who is a professor of neurology and pediatrics here at Columbia. She was born in Peru and attended medical school in Buenos Aires, Argentina, and then came to the U.S. to complete her her training in pediatric neurology and also in public health. She has served on multiple committees at the NIH, the Cognitive Neuroscience Society, the American Board of Psychiatry and Neurology. She has a very active clinical practice addressing neuromuscular disorders, developmental and neurobehavioral neurology, migraine, and the treatment of spasticity. But her main current research focus, and what we're going to hear about today, is spinal muscular atrophy clinical trials. So thank you, Claudia.
Thank you, Ruth, for that kind of introduction. Can we get the slides up, or I just go forward?
I'm sorry.
That's not mine. Do you want me to find it?
No,
Okay.
here we go.
That's
So you know how to operate that.
Yes. I never push the right button, but I know. Hello, everyone. I'm going to switch gears a little bit and talk about SMA and clinical trials in children, and then some of the ethical issues that we've encountered now that there seems to be treatment available for these children. So without further ado, these are my disclosures. And do I have the extra 15 minutes, or do I have to speak very, very fast? Okay. Okay, good. Thank you. So what I'm going to do is provide a little background of SMA in terms of why a single mutation causes such clinical phenotypic heterogeneity. Some of the results of the clinical trials that we participated here at Columbia starting about 6 years ago, and the fruit that we have borne from that, and the treatment challenges now that we face. Spinal muscular atrophy is a progressively recessively inherited neuromuscular disease characterized by weakness and muscle atrophy due to the loss of spinal cord motor neurons. The genetic defect is a mutation. It's a homozygous mutation of the SMN1 gene, and it's one of the leading genetic causes of death in children, second only to cystic fibrosis. The carrier rate is about 1 in 50. Before you ask, there are 2 recommendations. The American Medical College of Genetics recommends testing people, couples in general, and the American College of Gynecology only those who are symptomatic. And we can discuss that later if you'd like. And the incidence about 1 in 10,000 births, and there are several phenotypes. Oh, they translated the videotape. So the 3 types that you can see here is the SMA type 1. As you can see, that's the most severe phenotype. Can everybody hear me when I get away from this thing? It's a very weak phenotype. They never sit. They have a limited life expectancy. They're respiratory failure and early death unless they have respiratory support in a more permanent way. And it's the most common. As you can see the pie chart up on top, it's about 60%. The SMA type 2, which is the middle panel, are children who have an intermediate form. They're able to sit, and some of them stand, but they never walk, and they have a shortened life expectancy. The major complication are the skeletal deformities. The birth prevalence is about 27%. And in the far panel is SMA type 3, which is a milder form. And these children all are walkers at some point. They have a normal or relatively normal life expectancy. They have a proximal weakness that's prominent, and oftentimes it's in the differential diagnosis of limb-girdle muscular dystrophy or a Duchenne's. And the burst prevalence is about 12%. I'm not going to talk about the adult form, which is the more rare type 4 that presents after age 30. Just to say the type 3s, if they present under age 3, they tend to lose the ability to walk relatively early, and after age 3, they tend to keep that ability for several decades. Just to give you a little bit of natural history so you can compare that to some of the results that I'll be sharing with you. If you look at the first graph, that is from Finkel's paper from the PNCR network, of which Columbia is a member, that's showing the probability of an endpoint is either death or permanent ventilation, defined as greater than 16 hours. And as you can see, the median age endpoint is about 13.5 months. Very rapid decline in function. Dysphagia occurs even earlier. The CHOP intent, which is CHOP because it was developed at CHOP, the infant test for neuromuscular disorders, just shows that it declines over time from about 20-something to less than 10 oftentimes, and a decline of 1.27 points per year. This is the natural history of the type 2s and 3s. The top panel, there we go. The top panel is just to show, and this is a paper by Petra Kaufman from the PNCR network, just to show that if you observe over a year of life in this prevalent cohort, there's not really a big difference. And just to go over this a little bit, this is the mean change in a functional motor scale called the Hammersmith Functional Motor Scale Extended. But if you follow over 3 years, you do have a decline of about 1.7 points on the Hammersmith over 3 years. This is just to show what we were talking about, the type 3 A's and the B's. If you look at by 20 years, 44% of the children are ambulating as opposed to 90% of the 3B, those who present later. A much milder phenotype the older you present. So we talked a little bit about how it's an homozygous deletion of the SMN1 gene on chromosome 5q13.3, and that causes 95% of the cases of SMA, and that's the mutation we'll be talking about because that's what's been targeted with this RNA treatment that I will be discussing in a bit. In humans, there are two forms of the SMN gene. One is the SMN1 that's absent, and the SMN2 that is unique to humans, and everyone has at least one copy. So there's an inverse relationship between the SMN2 copy number and disease severity. So in the green are the ones, it's about a mean of 2 copy numbers, 3 for the type 2s, 3.5 for the type 3s, but there's a lot of overlap. So some children have 2 copies and are a type 3 and are very strong, and some type 1s have 3 or 4 copies and are very weak. And some of that is certain mutations that are providing a milder phenotype, but others are unknown and are under study at present. And as you can see, the controls, it really doesn't matter how many SMN2 copies you have. So this is to explain the alternative splicing that helps explain why this SMN2 copy modulates the phenotype. And in the red, you have the SMN1 that has this transcription of all 8 exons and gives you a nice, robust, full-length SMN protein, which is the one that's clinically active. And then you have the SMN2 that has the C for T substitution that skips this exon 7, and if you're missing your exon 7, that truncated protein doesn't work at all. But there's an alternative splicing. Sometimes they skip the skipping and you get the full-length SMN protein. And so about 15% of the transcription is a full-length functional protein. And the more SMN2 you have, the more of that functional protein you will produce as part of this alternative splicing. So just to explain a little bit of the RNA-based therapy, with SMA, you don't have SMN1, and everything is derived from this alternative splicing. And so the treatments are targeted to kind of increase this alternative splicing from the SMN2 gene and produce more of that full-length SMN protein that's transcribed. And how is that accomplished? Well, this medication that I still know is ISIS 396643, because that's what we're injecting experimentally, later named RX-ISIS, and now nusinersen, is an antisense oligonucleotide that promotes the splicing of the SMA transcript to make a full-length SMN protein. And you can see it here binding to the HNRP to promote this exon skipping of the skipping exon. And so you get more of the full-length SMN protein. Just a little bit of background of all the studies that we've been involved with. The two that I'll speak about most, which have publication, is this first open-label study, and then this other open-label study. This is for infants, and this one is for children. And then there are controlled studies that have been closed. This is CS4, which is for children with type 2s, and this is phase 3 in type 3s, type 1s, I mean CS3B. So let's go. This is the paper that was published in March of 2016. And just to go a little bit over the protocol, this was a multiple dose, 1, 3, 6, and 9. And I'm just going to show here that there's a loading dose at day 1, at day 29, and at day 85. And it was mostly safety and tolerability, but we were looking at that Hammersmith. And this is the Hammersmith change in functional Hammersmith score. As you can see at 29 days, maybe the 9 milligrams has a little bit more, but 1, 2, and 3, really no change. And at day 85, you start to have a statistical change in the 9 milligram treatment of about 3.1 points. And over time, we've treated these children. We were the first to dose ever in December of 2011, and we've continued to follow them and treat them over time. If you see at the 9-month end, there was a 3.1 change, mostly in the 9s. After this 9 point, everybody was given a 12 milligram dose, and then they were continued over time, and this is up to 14 months, and you can see there's almost a 6-point difference in score. So motorically, the children are getting stronger. These are type 2s and type 3s. And there was no restriction as to whether they could have scoliosis, they could have rods, or how weak they could be. This is just family who allowed me to show you these. I'm not going to show you the videotapes in interest of time, but she was one of our younger 2-year-olds who was enrolled. And at age 20 months, she lost the ability to crawl. So this videotape is just showing her creeping along. And she was dosed in October. This was 2 months later. By 3 months, she was starting to crawl on all fours. And by 4 months, she was starting to stand with a walker, and now she walks with calipers, transforming it from severe weakness to the ability to stand and to walk with assistance. And we've had a few children who are able to walk independently. However, not everybody has responded, and this is a slide that the FDA produced just to show that there's a group of children who haven't responded as well. They call them the non-responders. I would call them the stabilizers, because over time, and we're talking about many years, and this is total Hammersmith score, some of them, the older children with more advanced disease, tend to be a little less rapid improvement, but clearly they don't tend to lose a lot of function. I think this was an scoliosis repair that had a lot of function. So some children respond a lot, but others just stabilize. This next, I'm going to talk about the baby study. We showed the type 1s, the very severe infants. And this is just to show that all of these children were less than 7 months of age, and they couldn't be on permanent ventilation. They couldn't be hypoxic when they were sleeping, and the dosing was a little more frequent, day 1, 15, and then every 4 months that they were dosed. And this was a 6 and a 12 milligram cohort. right? And most of them were. And just to show you over time, one of the outcome measures is the milestones. Over time, grasp, kicking against gravity, head control, rolling, sitting, crawling, standing, walking. And the blue is the 6 milligram, the red is the 12, and the yellows are those who have 3 SMN2 copies, who might be a little stronger. This aqua is a young girl, one of our earliest treated children, who has 2 copies of SMN2. And over time, you can see that there is improvement. And some of them are sitting, and some of them are even standing, so that there is quite a bit of improvement in these motor milestones over time. Just to show you, this is a nurture study. This is pre-symptomatic. So if you capture children at the time of birth, and this is, Wendy Chung has a newborn screening test for all of NYP. And we've had a few children come from there, others from sibling of children who have had SMA. And they're treated before the symptoms become present. And you can see that those patients do very well, and I'll show you a little bit more of how they're doing. So treated before the onset of function, and of those with SMN2 copies, 20% of them are walking, and those are children who shouldn't be sitting even because they're type 1s. The ENDEAR study is the placebo-controlled study. It just shows that there are lots of doses, placebo-controlled, with nusinersen sham, day 1, 15, 29, 64, and then every 4 months. And if you follow them over time, and it was closed at 15 months because 41% of those who were treated improved versus none of the ones who received sham. And so clearly there was a difference, and the study was closed. This is a slide that shows you total milestone score over time, and it has all of the infant studies to show you what to expect. So the first 2 are the placebo-controlled study. This is the sham. Looks a lot like the natural history with the progression and loss of function, versus treated children do very similar to the CS3A, the open-label infant studies, who have longer period of time that we've been following them. And lastly, if you compare that to the nurture babies, the ones who are treated pre-symptomatically, they have done the best. Many of them walking and appearing to, for all intents and purposes, normal motor milestones. So finally, in terms of the studies, this is the older child placebo-controlled study that is SMA type 2. These were children who were a little less severe than the open-label study and only type 2s. Treatment versus sham. They had to have SMA present before age 6 months, and the outcome was the Hammersmith Functional Motor Scale, and they had this interim analysis at 15 months. And if you look at the slide, you can see that at around 6 months of treatment, the 2 curves diverge, and it drops precipitously over time. The sham group, whereas the ones who were treated continue to improve, and they have a total change of about 4 points in the Hammersmith Functional Motor Scale. Just to orient you a little bit, 2 points on the Hammersmith is going from not sitting to sitting, or from not walking to walking. So these are big milestones that are being achieved. And about 57% had the 3-point improvement as opposed to 21% that were sham. Now you'll ask, why do they continue to improve here? Well, that's part of the natural history of the disease. Very young children, between 2 and 5, the developmental curve goes faster than the disease progression, so they'll improve, but then the disease catches up with them, and then they can lose their milestones. So all of this led to the submission to the FDA and to the approval of nusinersen, known as Spinraza. Not sure why they chose that name. And it's indicated for SMA of all types as of December of 2016. There were little differences that were recommended. It's the 12 milligram intrathecal dose that is recommended, and there were some side effects that were found, the platelets, the proteinuria, none of that really symptomatic. It was more of a laboratory finding. But now we test for that beforehand, and the administration schedule is a little more intense, and the thought being that the older children were receiving less of a dose relative to their size, so that they should receive the same as the infants did. Day 1, 15, 30, 40, and then every 4 months. And now we are transitioning our older children, who are now receiving it every 6 months, to every 4 months as soon as that is approved. So this is primarily what I'm going to talk about today, the treatment challenges that having nusinersen available for the entire population of patients that we treat. So in an SMA clinical research center like ours, we follow maybe 150 children with SMA, and adults too, maybe 40 adults. And so that most people do want to be treated. And we do want to provide a very fair and equitable prioritization of treatment across the population of all types of SMA, and to also take into account the risk-benefit. Is there a risk for a very weak type 1 who needs intubation to get under fluoroscopy when they are very weak and can't really tolerate the procedure? Anesthesia would say the risk is too much if we have to anesthetize and intubate. The family may not agree. And the other thing is that it's a costly medication. It's about $125,000 an injection, an intrathecal injection. That's $750,000 a year for loading dose, and $75,000 yearly thereafter. So how best, with our limited resources, both physical, because you need the ability to make to perform those procedures, and we need sometimes fluoroscopy suites, we need sedation for the young infants, and you need more than just lonely me to dose all of these patients. So how do we best determine who would benefit from the medication, and who do we treat first? And I think that's been the biggest issue, is who should we treat first? The beneficence that you were talking about, who would benefit from medication, and who has function that can be rescued? Or who is losing function the fastest that's there to recover, and who takes precedent? And then, once we start treating, how do we assess the response to medication that justified continued use? And I don't know that we have all the answers, but have some ideas. So the evolution of SMA over time, and just to show that I would suggest that there are 3 stages. One is an early stage, shortly after diagnosis, that's when we see the greatest loss, where they're normal and then they suddenly start losing milestones, and that's probably, here you can't see very much because they start very low, but the type 1s lose the fastest and then they plateau. And so they'll lose the ability to breathe independently, to move, to swallow independently, and then they're in a stable situation. But they still may have some hand movement. They may be able to operate an iPad. They may be able to learn, go to school, because they have a little bit of function in one hand, which we have termed to be a critical function. Not an essential function, but a critical function to their ability to negotiate the world. And then there's an intermediate stage where there's this stability or slow progression. The slow progression we see more in the type 2s, where they reach a plateau and they kind of stabilize, and it may be a very slow progression, as we saw with maybe taking 2 years for 1.5 points on the Hammersmith. And then there's this advanced stage where there's evidence of chronic changes, those children who have scoliosis repair, fusion, fibrosis, that really makes it a little harder to decide how much improvement are we going to see in these areas. So for the type 1s, that might be 24/7 respiratory support. For the type 2, it might be very advanced fibrosis of the muscles and legs, profound upper extremity weakness. For the type 3s, it may be that they become non-ambulatories and are behaving like a type 2. So how do we prioritize treatment? Well, after a lot of soul-searching, ethics committee, SMA treatment boards, we've developed a scheme in which pre-symptomatic treatment is probably the norm. And we don't yet have pre-symptomatic diagnosis. So there is discussion for doing newborn treatment, newborn genetic testing, so that we can have early treatment. Up until this time, any effort to have it placed on the newborn screening was never accepted because there was no treatment. So if there is someone who's newly diagnosed or is identified pre-symptomatically, that takes precedent, because even a weak treatment, you can lose a lot of motor neurons and have a suboptimal response. And then those need to be diagnosed and treated as possible because of that early loss, and they have priority of treatment because they have the potential for the greatest loss in function. Those are the pre-symptomatic, and the symptomatic also should be treated as soon as we can. The recently diagnosed before the onset of endpoint, that is respiratory insufficiency, early symptomatic type 2s and 3s before the chronic changes. And then how do we decide on how to prioritize the treatment of the rest of the children with SMA? And everybody wants to be treated, and we don't want to discriminate against anybody. But again, the insurance companies are doing a lot of that for us, making some pre-qualifications and some changes and an improvement to response. So this is just to shed a little bit of light, because we don't have a lot of natural history studies of treatment. But if you look at the Delta 7 mouse, which is a very severe mouse, maybe like a type 1 that dies by 9-10 days, you can see that the earlier you treat, the better the response. So if you wait until day 8, or you get very little response, and if you wait until day 10, you don't get any response in survival. So clearly early treatment is better, and there may not be a lot of improvement over time. So the late rescue really has nil improvement, and that's likely due to the absence of end organ effector, the motor neurons for recovery, and it's not clear how do we extrapolate this information to inform the clinical decisions. So some have advocated that we should give priority to those who have qualified for the study, that we've only really established the evidence-based medicine in children who justified criteria for entry into the placebo-controlled study, which I feel is very restricted. And it's restricted to the point that there were no clinical trials on type 3s. So are we not going to treat children who have lots of SMN type 2 that are likely to benefit? No, I don't think that this really applies. Now, insurances are having exclusionary factors, and for example, they have bizarre respiratory support, like if you have 6 hours of respiratory support, you can't receive the medication. And that means that we have to appeal multiple times. And then anesthesia has some risk-benefit analysis. They really don't want to intubate any of the very weak type 1 children who don't have tracheostomy if they need fluoroscopy, because when they're prone, they can't see how they're breathing, so they can't have a BiPAP machine. They'd have to be intubated. So that makes it a little questionable as to what to do, and if we're able to, we'd like to do that, but only if it's safe. So response to treatment. The insurance is requesting that within 6 months of treatment we show that there are improvements, and this includes 3 points on the Hammersmith, which, as you saw, we saw close to 9 months after treatment. So that's a very tall bar, and I don't think that's the appropriate amount of time to wait. So we're saying maybe 12 months, but is that the appropriate time? I really don't know, and so we'll just have to see how things play. We'll try to treat as long as we can, and I think patients themselves realize sometimes that it's a lot to have so many intrathecal injections that many don't want to do it, especially if it's very advanced and cumbersome. The FDA has termed these non-responders, and it's more of a stabilization, because if you wait long enough, then they could respond if they're stable. But I think the issue is how long will we treat to decide that this is an effective response, given how cumbersome, how labor-intensive, how risky spinal taps with anesthesia could be in children. So I don't know that we have the right answer for that. So to conclude, I think there's a need for newborn screening. We know that. the carrier testing helps, but not always is that translated into early diagnosis. We had one patient who should have been in the pre-symptomatic treatment arm because both parents were carriers, and they begged the pediatrician to do the SMN in the child, and that was not done until the child was symptomatic, and by then he was too late to receive the pre-symptomatic treatment. He got randomized, did likely not receive the medication, and now is on 24/7 ventilatory support. That all of this because we didn't identify the treatment early. So newborn screening will preclude that. Once we treat early, we won't have these issues of how far advanced the disease is because everybody will receive it in a timely fashion before they've established those chronic changes. But we have a lot of pent-up demand that we need to take care of. So the prioritization, the pre-symptomatic, the early stage, the intermediate stage, and then the advanced stage. The SMA Treatment Board, Ms. Hirano, and the neuromuscular team have kind of set priorities of critical milestones and essential functions that are going to be our goals, and we hope that we can justify that to the insurance to justify treatment. And in order to do this in an unbiased way, there's an independent board to assist in prioritization. We suggest patients to be treated, but it's done independently of us, which at the beginning, as a clinician, I was very upset about, but I understand that it's important to have an unbiased person making those determinations. And how long do we treat? And it depends on the response, and I think we'll have to figure out what that involves over time. But further, we don't know how long we need to treat at this level. If you look at rodent data, SMN is more of a developmental protein. You need a lot when you're growing, the infants, adolescents, and then there's a maintenance requirement in adulthood, which is much less. So it could be that this regimen can be changed a little bit once these children reach adulthood. And this is the group I work with and everybody that's been involved in this study. And with this, I will close. Thank you.
Such a success story.
Yes, thank you.
Thank you. I have two questions if I can. One, I'm curious about the use of the sham intrathecal injections, and just I'm sure, I guess you decided to use that versus a natural control getting placebo just because parents may do something differently, but presumably there were objective measures of the development of the kids. I'm just curious about that, if that was a concern. And secondly, I'm wondering if you've had requests for compassionate use or expanded access, if it's the access is being limited, if that's come up or might come up, if there's been a protocol how to deal with those.
Right. So the first question is with regards to, I'm sorry, what was the first question again? Oh, the sham, yeah. Well, it wasn't our idea. It was a requirement by the FDA, who demanded that they didn't want the typical natural history comparison, even though there is a lot up-to-date comparison. They really wanted real-time comparisons. So the sham was not an intrathecal injection. It was actually taking them to the IR suite, pricking their back, taping them, keeping them half an hour to kind of make it that they were really being dosed, making fake CSF so nobody was the wiser, and having a blinded and unblinded team. So, and we're still keeping the blinded, even though now everybody is going into the open extension. So that was a requirement, and a lot of families were very upset, especially in the type 1s, because if we didn't treat them early on, that window of opportunity really passed. And that was very sad to see that difference between the treated and the untreated. It's not going to be an issue going forward, but they missed that window, and they're clearly different than the children who were treated. And it's unfortunate that that's what was warranted, even though the CS3A data was very strong and showed that 70% of them didn't die, didn't need permanent ventilation, and it was a success story in that regard. The expanded access was something that was offered early on before it became commercially available. We here were very overwhelmed because we have like 40 children that we dose in all of the studies, so we didn't participate in that study because they provided free drug but nothing else. And it was a lot of work just to get things set up and expanded in that way. The company does provide, at least for the time being, free drug. If you are refused 2 times, you will get free drug. But that's also a problem for the hospital, for us, because free drug doesn't take care of everything else, and if the insurance isn't paying for it, how do you support that long term? But yes, and they have been very flexible in providing drug interim until the different pharmacies talk to each other, because right now the approval for nusinersen will be provided, but then they don't, the pharmacy part of it is not approved, so we can do the procedure, but they don't give us the medicine, and so that's been a problem. Currently, we've been dosing type 1s in the office, and we've done maybe 10, part of this clinical. We haven't been able to treat anybody in the hospital yet. There was a little bit of a delay because of the pharmacy contracts and what have you, but now that's cleared, and now it's getting the insurances, the pharmacy aspect of the insurance to approve it. So we have several down the line that we will be dosing as soon as those approvals come through.
Thank you. I think it was a fantastic presentation.
Thank you.
And this last part, which is really, the consequences of a great event that has a drug approved, is the spin of the practical use of the drug. And the way that the prioritization is organized seems to be very thought through. But people have all the tricks to turn around things. Doesn't people go shopping around if they are turned down? Let's say, the American system is open. People can go to the next shop.
Absolutely, and they do. And we know, we're in touch with other groups in the area, so we kind of know where people are submitting their starter forms, and we try to avoid that as best we can. And people are encouraged to go elsewhere if they have the opportunity to get started earlier, and that's not a problem. The insurances have done one thing further, which is to demand that everybody have all of the testing that have been done from the clinical trials, the Hammersmith, the CHOP and TEND, that most routine places don't have that availability, so they ultimately do need to come back. What we are trying to do, because we realize that we're not able to service everybody, is to provide that service as long as they come back to us for, the regular 2 times a year treatment standard of care, to provide that so that other practitioners can deliver the medication, because we realize that we cannot dose everybody in a timely fashion.
Okay, thank you very much.
Thank you.
Actually, one of them should be this one, so I'm going to hand it to you as soon as I'm finished talking. So you're going to stand over there, Sam? Okay. So we've come to a point which for me is very exciting. This is a panel discussion that actually Karen organized. What would you like? Did I do something wrong?
No. The panel should use this one?
The panel should use this one because this one will be recorded. So, all right, so let me have one of those.
Okay. You can put that there. Thank you. Okay.
So I'm going to introduce the moderators of the discussion, and then I'm going to introduce the panel participants. The three panel participants.
She's coming back in a sec. Start with us.
And many of you know Karen, but she has been such an important part of this conference and also such an important member of our faculty here and member of the community that does research on neurodegenerative disorders. She is the Sally Curlin Professor of Neurology and Chief of the Division of Aging and Dementia here at Columbia. And since its inception, she's also been director of the United Council for Neurologic Subspecialties Fellowship in Behavioral Neurology and Neuropsychiatry. She's also the founding and current director of the Huntington's Disease Society of America Center of Excellence here at Columbia. And she is a very active researcher and clinician focusing on epidemiology and treatment of cognitive, behavioral, and motor impairments in a whole range of neurodegenerative disorders. So the other moderator is also fabulous, and he is Dr. Edward Huey, goes by the name of Ted. And he is a geriatric psychiatrist who is assistant professor of psychiatry and neurology here at Columbia in the Taub Institute and the Sergevsky Center. His research focuses on cognitive and psychiatric symptoms of non-Alzheimer's dementias, notably frontotemporal dementia and also Huntington's disease. And he's particularly interested in the earliest symptoms of these disorders and what we can learn from them about how the brain processes emotion, social cognition, and complex behavior. So, and now our three panel participants, Kevin Baker, on your left, I think, if I have my spatial orientation right. Stage left. Kevin is a novelist, historian, and journalist. You probably have read some of his articles in the New York Times. He's a frequent contributor to many periodicals. He's also the author of 5 novels and 3 histories, and he's right now finishing a book on the history of New York City baseball. And he will wax eloquent about it if you would give him a chance. Shane Mulhern, stage right, is an educator and lives in Washington, D.C., was most recently director of the Investing in Innovation Fund at the U.S. Department of Education. Now he's working as an independent consultant. And he's an avid race car driver. Lorraine Kopczynski works in the food industry as a regulatory manager, but her most important work is caring for her 7-year-old son, Chase, who has spinal muscular atrophy. So thank you very much for coming.
Thanks for having us.
You can unwire me now.
Good afternoon, everybody. This is, I think, the most exciting part of the day for us. Oh, I don't need that. Okay, sorry. So I think we've heard a lot about Alzheimer's disease. We've heard about SMA, Huntington's disease. Now we're really privileged to have 3 people who are really pioneers, who are really experienced in clinical trials. And I'm really delighted to have them with us today and really happy that they could take the time. So I thought we'd begin by just asking each of you to take a minute or two and just tell us about the clinical trial that you're participating in. So, start, Kevin?
Yeah, I'm taking part in the Signal trial for Huntington's. It's one of several I've been involved in since testing positive for the gene for the disease 10 years ago. It basically consists of monthly trips up here, and a series of cognitive tests, every few months an MRI and a PET scan, and an infusion of an experimental drug that it is hoped will preserve brain cells, which is kind of the whole ball game of somebody my age. So that's about it.
Hi. My son Chase is actually involved in the SHINE study under Dr. Boga's team. So he's been in this trial for several years now. So we've been extremely fortunate, our family and especially our son Chase. He was diagnosed with type 2 SMA at 14 months, and he was diagnosed here at Columbia Medical Center. And at that point, the medication that Dr. Boga spoke about was not in existence yet. And as Dr. Boga mentioned, she started the work on neurosurgeon in 2011. My son was born in 2009, and we were diagnosed at 14 months in 2010. So we have been involved, thankfully, to the team at Columbia. We were asked to participate several years ago. So my son has received the 9 milligram dose that Dr. Boga spoke about, and recently the 12 milligram dose. So we do come regularly. There is a specific protocol, as she spoke to, as far as having periodic testing, coming in for the exams to understand his motor milestones and what he's increasing and where he's showing difference. So they have clear testing to be able to gauge those motor milestone points. Yes? Sure. Okay. How come you?
More of a loudmouth.
Okay. So we do participate, as I said, regularly we come in for treatments. We do go do the LP and under general anesthesia for my son, but we have definitely seen some improvements. I mean, he is type 2, so as you saw in the video, there's definitely different ranges of type 2. So we're grateful that our son can hold his head up. He does drive a power chair since he's been 2 years old. So he does have his independence. He's in school in first grade, mainstreamed with all the other children. And he has a home health aide with him during the day to help him with all the ADLs. So transfers for toileting, assistance with eating during the day, and any schoolwork assisting. But, he's really thriving. He's doing well socially and emotionally. And, in our home we call it the super medicine. So the last dose when he came home, it was probably a few weeks later. And, we do some belly time with him to stretch out all his muscles since he's sitting, most of the day and standing some of the day. And he told me a few weeks ago, he said, "Mom, I think it's the super medicine. I can lift my head up." So he was able to do it for a few seconds. And, because he's scared for the procedures and he gets, kind of wound up that he's coming in for the medicine. But he really does see some of the benefits. So I always use that as a reinforcement with him. Say, "That's why we get your super medicine. It's really helping you." And he's like, "Okay, Mom, so he's young, he's little, and he's understanding. He's been through the scoliosis correction. He has the G-tube for extra nutrition. So we have had to do some of those more medical interventions. But, overall, the participation, despite all the effort and the time, it's worth every minute. So, sorry.
Absolutely. So hi, I'm Shane. So I am part of the Diane clinical trial. I have a family history of Alzheimer's. My mother, my grandfather, 2 generations before that. It's actually nice to see Jill again. She was, had a conversation with her 7 years ago when I was thinking of getting involved in the observational study. So I do not know my status. I have decided not to find out if I have the APP1 gene or don't, but have decided that the involvement in the study and participation in the clinical trial hopefully, if I do have the gene, there's some benefit to me, but to be part of this for, in honor of my mother, who actually came here for 15 years, and for my 3 children, to try to help kind of address the scourge of Alzheimer's.
Okay, well, thank you very much for those introductions, and thank you so much for being on the panel. I mean, I know I'm really looking forward to hearing. We've heard a lot from the doctor's side, but hearing from the other side about these issues. So thank you very much for doing that. So the first question we have is that, I think a question's run through a lot of the talk today, which is whether you received genetic testing or not, kind of what were your motivations? What were your motivations for getting the testing? What were your motivations for not getting the testing? And I think we have a kind of range here. So.
I know for me, well, a number of reasons. One, the 50% yes or no, which is Huntington's, was not enough to really feel secure on. Maybe if it had been 1 or 2%, I wouldn't have done it, but at 50%, it felt, more unnerving than not. Another big motivation was having seen my mother go through the disease, and she was talked out of getting tested early on by another relative who was a little emotionally unbalanced, and that did her absolutely no good. She lived in a small town, and people thought she was drunk. People thought she was strange. Whereas I think they would have been much more sympathetic and helpful if they had known what was going on. And the same thing with her husband, my stepfather. I think that would have been all gone much better the earlier she had gotten tested. So I wanted to see, I wanted to get it right out there with me, find out what the status was, and take part in what trials I could and see what could be done about it, if anything. But above all, I wanted to face it, sort of face on and deal with it that way.
Just to speak from our family's perspective, so my son, was born healthy. I was full term, 39 weeks, and, he was a robust, normally developing little boy, and, my husband and I have pictures of him in the toddler tub, punching and kicking and doing, he's our first son, so we just said, he's doing just fine and doing normal, expectations for an infant. And, we would go to regular pediatrician visits, and, at about 6 to 8 months time frame, I know my husband went to one where I was actually working that day, and it was probably around 6 or 7 months, and, he wasn't increasing on his weight. And we said, I think that's a little odd that it's not continuing, because he was in, between probably the 50th and the 80th percentile for height and weight, just continuing along the progression, and I thought that was a little odd. I said, okay, well, let's keep an eye on it. The next visit I went with my husband, and we said, something's really going on here. So I remember, and it's a bit of a harsh story, but the pediatrician had said, well, just, hang him off the couch, because I said he's not scooting, he's not bearing weight, he's not, lifting up. And my husband's like, I cannot hang him off the couch because he's not able to weight bear. So then we had actually seen the head of the pediatricians group at the time, and they said, I think you need to, look into this a little bit further. And then we came here to see the neurology team, and that's where we found out, that there's different. I thought it was actually low muscle tone, and thinking obviously positive about things. So we initiated physical therapy, and in the meantime, they recommended some blood work for our son. And then on December 17th of 2010, we were told by phone that actually he has SMA. So we were just really kind of floored with the whole diagnosis, but really just started to learn at that point and tried to understand more about the disease and what does it mean for him and what does it mean for our family.
So it's interesting, kind of hearing about the 50-50, because that's sort of my odds. I actually think of it kind of, I conceptualize it as it's 100 or 0 in my head, and kind of how it helps. I don't want to be defined by this disease, right? And I think if I found out my status, it could define me. At the same time, so I have 2 siblings who have the same probability, and I have 3 cousins whose father, my mom's brother, also have the same probability. And so that's the why, right? It's the 6 of us. It's the, let me do my math right, it's the 11 children under them. That's the purpose for participating, even though I haven't found out my genetic status. It is going, if you add up those 17 people, math is not on our side.
Just to speak to that briefly. Now, I understand what you mean. I wrote about getting the tests and all for New York Magazine, an article out in 2008, but I have not really written about it more, in part because I don't want to be the Huntington's guy. I don't want to be the guy whose writing career is defined solely by my disease, so I can completely understand that.
Thank you very much. So, one thing we've been talking about kind of all morning is the interplay between research and genetics and genetic testing. And did that weigh in any way to the decision to get tested, not get tested? Was it a motivation to pursue testing or not? Just what was the interplay there for you all?
The interplay.
To do the clinical trial and testing.
What was the interplay?
Did you consider, was it a motivation in testing, not testing? Or,
but it could, yeah. I mean, there's a big motivation to try to go into trials and do things. And, that was, as we were, I don't know if I would have gone into trials if I had tested negative. It's funny. We were joking a little about people on one of the presentations, which were great, by the way, about people feeling disappointed if they didn't have the disease. And that was one of the things I was told, too, was like, when you get this test result, no matter what it is, your life is going to change completely. And I felt like if it's negative, no, it's not going to change completely. I'm going to do a little dance and, be out of here, and it'll just go back to being what it was. But
I could just comment, there's a very large, strong support group for SMA families. So when we were first diagnosed, they actually offer a complimentary scholarship to attend. It's called Cure SMA, to attend for newly diagnosed families to understand. So I remember at the time it was Dr. Doug Sproul who shared the diagnosis with us, and he said to me, "Lorraine, are you sure you want to attend the conference?" And I said, "Well, what do you mean, Dr. Sproul?" He says, "Well, you're going to see a lot of things. You're going to see the progression. You're going to see different severities. You're going to see type 1s to type 3s. You're going to see infants to adults. I just want to make sure from an emotional standpoint, you're newly diagnosed." Chase was we didn't see so much of the effect, although not ambulatory. We didn't see a lot of the muscle loss. He was still eating very well. He had appetite. He was, so we weren't seeing it. And I said, I really want to educate myself, and I really want to learn, kind of the path and how to, if we can prevent things or manage things in the best way we can. So when we did attend that one, it was in Disney in Florida, and I remember it very well. And we were sitting actually having lunch, and there was another family next to us, and families actually came up to us in the swimming pool. They said, "I'm sorry, but I don't want to, come to you, but does your child have SMA?" And I said, "Oh, absolutely." And they said, "Oh, they're so familiar with some of the symptoms that they approached us and made us feel extremely welcome." But I would say, to answer their question on participating in the trial, seeing the children and seeing the progression of the disorder in our eyes, and I never forget a lot of the children I saw, which was, it was 5 years ago. I remember them like it was yesterday, and I just said, my goodness, if there's anything out there that we can do for Chase to make sure that we can minimize the impact. And when this trial came to us, we had our reservations on, what will this do? Is there any safety issues? Should we worry about this? And, based on what we saw in that conference, we decided we need to do all that we can to try to delay or help him in any way, because it was not, some of the progression was, very unsettling to all of us. So we said we need to do everything we can. So when this opportunity came up, within, I received the phone call at work one night, and they said, "You have 24 hours to decide if you'd like to participate." And I hung up the phone, and I called my husband, and I called my mom. I'm like, "What do you think?" And we all said, yes, yes. I mean, how could we even think twice? So that's how we became part of the study here.
And I think there's a little bit of theme, and I know for myself, it is the mix of being part of something larger with the personal benefit, right? If I have the gene, I hope I am in the 75% that is receiving the drug. But, I did the observational study, and that had a lot to do with wanting to push research forward. I mean, I'm sitting here, and it's kind of, I actually just had a realization I'll share. Like, my mother's brain, or part of it, is in this building or one of the adjacent buildings, right? And there's kind of this, wow, she really had this kind of deep sense of wanting to do it for, her children, me, and kind of the research side of this, and I think about the next generation, right? So there's a self-interest, but then there's kind of like, how do we move this field forward? And kind of participating alongside all of you who are doing the deep science side of it, and for some genetic anomaly, like, we can contribute to that.
So you anticipated our next question. You kind of basically, answered it already, Mr. Baker. But the question was, have you participated in research that did not provide the possibility of direct benefit to you, so observational trials, and then what motivated you to participate? So you, I think, answered that very well. Maybe the other two of you can.
Yeah. When we first enrolled in the study, I think, back...
It's okay. Baker. You have little pictures, you guys will figure it out.
When we actually enrolled my son, so he's been involved in the now Spinraza, but when it was experimental at the time, it was several years ago, and there wasn't, that level of certainty. It was a learning, it was safety, it was efficacy. They were still down the path of understanding the medication, and does it work, and does it provide benefits. So there was, that uncertainty of this, will this help and will it not? But for the benefit, and my husband and I felt, for the benefit of our son and for the SMA community, this is our, to help all the future families. This would be an opportunity to not only possibly help our son, depending on how the course of the testing went, but also for other families that would like help for their children.
Yeah, I guess I would participate in anything that would be helpful with that. It's I originally was going up to Boston, up to Charlestown for this, and I don't know if I would have done that necessarily if I had been negative on it. But yeah, anything that would be observational that would help in any way with the disease would be happy to take part in. So, yeah, but I'm positive, so it is self-interested. But yeah, so.
Switch gears a little bit. Can you tell us a little bit about what you think has gone right in participating in research and what the challenges are?
I think it's been terrific. I think it's you were saying, sort of connecting to a community is good. Feeling some sort of support. It's aside from the needles. I really like coming up here and taking part in it. Could do without the needles, but it's terrific. It's great interacting with you, Dr. Martyr. With I know Paul Wasserman and Rhonda back there, who are my, clinicians. Is that the term? But terrific to deal with. Paul is always apologetic if the machine isn't working that day, or they have to push something back an hour, and I'm like, you people are devoting yourselves to making my life better and extending it, and so don't worry about it. I'm happy to read the paper for a few minutes and wait. So yeah, I feel it's been very positive in that sense, and it's been an overall a very good experience emotionally, as well as hopefully doing something. So the challenges are, well, the needles, but the challenges are kind of the pushing and probing and the time, but even that is somewhat compensated for monetarily. So there's no real kind of downside to it. It's another reminder that I have this in the future coming up here, but that's something I think about anyway periodically. So it's really not a bad thing at all, I've found.
I can comment on our aspect. It's been very positive. I mean, as you can see by Dr. Boga's presentation, this is an experimental drug that actually went to FDA approval. 2 days before Christmas, when you check your emails and you go on to the Cure SMA, there's a huge banner saying first ever approved treatment for SMA. So, I mean, to be able to be ahead of that and be participating in a trial and not really knowing which direction, because when we first attended the conferences, they would show you all of these maps of all the medicines that are currently in trial, that have been in trial, and nothing had ever made it to FDA approval. So it wasn't overly encouraging when you were newly diagnosed and seeing that nothing is really showing tremendous progress and even getting to FDA approval. So for us to be involved in the trial and having an approval and being able to continue to receive the drug, I know we mentioned some of the insurance challenges. We're fortunate that we're actually re-enrolled in the next phase of the trial, so we fortunately don't have to have those battles quite yet. But it's been obviously very positive for us. My son probably, I don't know if he would respond exactly the same. When it's over, it's all good. When it's not over, it's not so good. But he's getting, I would say probably a little bit more used to it, but, he's much more aware. When we started, he was much younger. And now, my son doesn't miss any little sneeze or any little trick, so his awareness is higher. So he's still a little apprehensive, but I think I keep encouraging him the benefit and saying, I tell him all the time, I said, there's so many children around the world that just want this medication so bad, and you're getting, you're so lucky. I just try to do some psychology with them, but sometimes it's successful, sometimes not so much. But
so I'm really going to take this opportunity and start with the challenges, because, I have a captive audience, and there's been a lot great, and I will get to the great, but kind of sitting here and listening to some of the presentations, a couple of big things. Mental health has to be brought into this in a big way. I have no problem saying 6 months ago, started seeing a therapist, best decision I ever made to start talking through these issues. These are hard life issues. That is not built into the study as an option, right? Not that it's forced on anybody, but it's literally a mind trip in so many different ways. So that would be one thing I would strongly encourage. The other thing, kind of listening to the speakers and some of the questions, I think conceptual models are going to need to shift a little bit as you move into the space around genetics, right? Even hearing kind of the conversation about informed consent. I was hearing people talk about it in a binary fashion. You're informed or you're not. Doesn't work that way from the participant standpoint. I started Diane before I did my last job, where I ran a $1.5 billion fund within the Department of Education to fund innovation, and there were randomized controlled trials attached to every project we funded. So I really got to know what an RCT was. And after doing that, I was like, oh, this is what I got myself into, right? And I would have never realized the depths of what I'm involved with if I hadn't had that job, right? So that sort of binary notion, and it's hard because we've got to move these studies forward, and I appreciate that, but that's complex. And then the third thing that I thought was really interesting that we don't talk about and is such a taboo, right? The suicidation, depression language. What does end of life look like, right? Especially for people who know, wow, out of my 42 years, I have had 25 with a direct family member suffering from Alzheimer's in the house. I know what my future looks like if I have a gene. Oh, what decisions do I want for myself? To me, everything should be on the table, and that's a conversation we're just at the infancy of. So the people are amazing. The doctors, the care that I get, the responsiveness. So there's so much that's right. I'm just blown away by the care. So there's a lot good, but I started with the challenges.
Yeah, I agree with that. That's a good way to put it. It's and speaking to the point the doctor had before about was this paternalistic or not. I don't think it is any more than, say, prepping somebody for surgery is paternalistic, you know. I mean, I was very glad for the procedure beforehand, and going to not somebody who usually sees a psychiatrist, but I was sent to see one. That was terrific. I saw another one who was a person I respected, who a friend sees. It was great being, you know, questioned on it kind of sharply by Dr. Martyr. Why are you doing this? You know, all along, the social workers, it was a terrific part of it. And my mother, for some reason, don't know, she was with, I think, like the Harvard Medical Group, but for some reason was tested without any of that. And it was horrible. And my sister, who was with her, it was horrible for her. She reacted, she probably had Alzheimer's as well already by that point, but she reacted in a violent, furious, angry way. And so it was horrible for my sister, horrible for her husband. I still regret that I wasn't there to help deal with that. So that way of just doing it, bang, go in there, oh yeah, you have this, without knowing the person's state of mind and what condition they were in, was really, really bad. So I think the protocol is terrific, whether it's a month or 2 months. I think it's great. Yeah.
Okay, so the next question is, are you concerned with breach of confidentiality through your participation in research? And then sort of a follow-up, how do you decide who to share that information with?
For me, I sort of outed myself right at the start of this whole thing in 2008, and I'm self-employed, and so I had lucky enough to have relatively few questions about that. But yeah, it could definitely become something in the future. I mean, my wife and I get our health care through the Affordable Care Act, so if that goes away, this could become a problem. You know, something that reflects more on our society, I think, than anything else. But yeah, so it's, you know, it's something I'm aware of. I don't really worry about it because of my particular circumstances, but I know relatives of mine who are been quite worried about that getting out and how it would affect their jobs.
From an SMA standpoint, I mean, it's from a diagnosis. I mean, it is a blood test, so for us, you know, it hasn't been, if anything, it's extremely beneficial for us because it enables us to get treatment for my son. So with his diagnosis, we're able to receive the physical therapy, the occupational therapy, the speech and oral motor therapy. We're able to enable him to have his power wheelchair at age 2. So those types of equipments that he needs, standing, his mobility, I mean, his power wheelchair is his mobility, and it gave him so much freedom. Otherwise, it was kind of mom carrying him or being in a stroller in kind of mom's control, as you can imagine. So as he's growing up, you know, he really kind of wants to be in control of as much as he can, because he can't control too much. But he, you know, having that visibility to his diagnosis has enabled us to get the treatments that he needs to just maintain his condition, if not improve his condition.
So it's a really great question, and for me, it's been personally complex. Well, obviously, I'm speaking publicly. I'm kind of fine sharing my story. I have actually wanted to share more and write about it, but my siblings are in a very different place, and it's this just very complex family dynamic. If I publicly share, I am sharing about them, and that creates just an added burden and added responsibility that, to be quite honest, I haven't figured out yet.
Audience questions. Should research studies be designed to give feedback on genetic or other data, for example, imaging that's predictive of the development of the disease? So I don't know, imaging findings or things like that was found in the study. What are your opinions on that?
Yeah, I think that's terrific. I think I'd like to know as much as possible myself.
I would say for predictive, if knowingly, for example, knowing, for example, my husband and I are carriers, just having that knowledge and being able to, if I were pregnant again, I would be able to certainly react immediately, knowing what I know, and be able to react knowing that there's now a medication out there to help.
So the timing question is great with Dr. Honig in Netherlands. Hi, guys. It's actually something I'm personally wrestling with, and I'll be honest with, don't even know about my study, right? If there are certain biomarkers that start to show right before, because that's actually, from what I understand, will probably happen. There will be biomarkers before stage 1 Alzheimer's sets in. I mean, I think I, at that point, would want to know, because it is then moving into kind of a clinical setting for myself to really have the kind of honest conversations with family and friends about, you know, what I'm going to do. And so, yeah, I think that's where research then gets very personal about sort of my health, and would want to be able to make decisions based on that information.
Well, maybe we'll open it up to questions people in the audience may have for our panel.
So this is a little personal, so if you don't want to answer, anybody wants to just pass the mic, that's fine. Some of you have kids, some of you don't. I'm wondering if any of you would be comfortable sharing what impact the genetic diseases in your families have had on your reproductive decisions. And feel free to pass the mic.
Thank you. With me personally, nothing. My wife and I did not have children, and we're past the age to do it. So really, we were lucky in the sense that it never came into play. I know one of my siblings has children and has not been tested yet, and you know, we have kind of a fractious relationship. So I'm not sure what her thinking is on that. I know some of my cousins have been tested, some not. So I think it goes back and forth. I think if you have kids, it would be, if I had children, it would have been a powerful move toward being tested, but I can't really speak on that.
Yeah, and I would just how personal of a decision it was. I mean, memories are flooding back. I remember sitting with Jill down that hall with my wife, getting my mother's genetic results, and deciding that I was not going to get tested, and we're just going to live. And I have a 7-year-old whose birthday's today, so I will be running out to catch a flight. I have a 3.5-year-old, and the statement that birth control is 99% effective, it's only 99. We have a 3-month-old, which violated everything that Diane was supposed to know. You're on birth control, yes, and sometimes it doesn't work. So yeah, the 3 kids, and it's personal. Like, do I worry about them? Unbelievably, is why I'm involved in all this testing. Primarily because of them, absolutely. But you just got to live is sort of what my wife and I came to.
I could just add just one more comment to that about the future and thinking about, there's not a second that goes by in our day just to wonder, how is the progression going to be for Chase? He's an only child. We don't have brothers and sisters for him. How is the care going to be in the future? Because it is involved. As you can see on the videos, although he's a type 2 in the middle, but there is quite a bit of significant intervention that's needed on a daily basis. There's not a day that goes by where, I don't feed him through the night for 10 hours at 50 cc of the formula that my husband and I battle on who's going to make it tonight. We have to, it's dedication, it's every day sticking to the routine and not letting one day fall, because one day without hydration and one day without nutrition will have a huge impact on your next day, on his behavior, his able to sit up, his ability to perform in school, to have play dates, to do activities, and it's very obvious if you stop the routine. And so it's it's dedication, and it's, but every day I think about, well, what about the future, and how do I manage this, and I want to be here forever. So it gives you a renowned effect on your own care, and how all of a sudden, eating your greens and exercising every day is becomes extremely important, because you want to really be there for him, and you really know all of the ins and outs of the day-to-day. So.
So that's a great, and there's some experts on the design that I will defer to in the room. So I decided to move over into the trial, excuse me, really for a whole host of reasons, personal and kind of kids and society. One of the things that appealed to me about the Diane trial is that if you are a carrier, I believe the design is 75% receive treatment, 25% placebo, and I was like, okay, those are better odds. I think and we did, my wife and I really did investigate that the two drugs that are being used in the two arms, right, had gone through phase, I think at that time, and I'll defer to the doctors in the room, phase 2 or 3 trials. So we knew they were relatively safe, right? I was not going to harm myself. So that was the decision around Diane. I think moving forward, and this gets a little bit into some of the question about kind of the pre-symptomatic but biomarkers, I would say personally I would be willing to take on additional risk for new drugs if I knew that, there are biomarkers that I'm seeing. Like, right, there is a calculus going on in my head in terms of, okay, what does my lifespan look like? What does my biology look like? And what risk am I willing to take on, and potentially sacrificing years for science or potentially treatment? Does that answer your question? Right. So I presume, and this is, I really would defer to the experts in the room, right? I'm getting PET scans. I'm getting spinal fluid taken out, right? So at some point, stage 1 Alzheimer's symptoms will appear, but I believe there are markers that will start showing up on those tests before those symptoms appear. And I think if those markers showed up, I would think differently about what kinds of treatments I'd be willing to undertake.
I think we have time for one more question. Yeah, why don't you give your phone? Yeah, go ahead.
Can I just, so one of the things, I just want to take a second to say thank you for all the work that you're doing, and I am totally willing to be contacted by any of you. If you have follow-up questions, just thank you for all your work.
Just going to say, too, that I think Shane said it very well. Thank you so much for everything you guys do. We really appreciate it. And it's nice working with you.
And if I could just take a minute and echo, it's been a pleasure to be on the panel and being asked to participate. And actually, Dr. Boga had asked me during one of my son's treatments, actually, when he was coming out of recovery, and said, "Oh, would you like to be a panelist?" And I said, "Of course." So, thanks to all the teams here, and then also for all of your participation.
So we were going to do some things at the end, but I think anything we could do right now would be anticlimactic and besides the point. So let me take a minute to thank Ruth for putting this together and Karen for the crucial role she played in putting this together, and all of you for joining us today, and of course our speakers and our panelists. We're very grateful to you for a really very interesting and really inspiring morning. So thank you very, very much.